Well, welcome everyone, and thanks for joining us here at our AOPT Imaging SIG um, uh, session this evening here on December 4th. And I'm Brian Young. I am the Vice President for Education of the Imaging SIG, and we are glad to have folks here in some interest of the SIG. And for those that are not able to join us but watch us on YouTube, thanks for taking time out of your schedules to be here to attend and learn a bit about imaging. And tonight, we are fortunate to have Dallas, and I'm going to butcher your last name, Dallas. I'm sorry. So please give me a prompt here.
Ehrmantraut.
Ehrmantraut. Okay, I was
Got
going
it.
to be close, but so Dallas Ehrmantraut, who's from University of Jamestown up in Fargo, North Dakota, and will be sharing some of his learnings and research and insights into imaging. And so, without further ado, I'll let Dallas kind of give a short intro to yourself, a little bit of your bio, your background, and then jump into who you've been collaborating with, and then your information, and then we'll open up to questions and other topics as we continue on for this evening. So, Dallas, I'll mute myself and turn it over to you.
Yeah, sounds great. Thanks, Brian, for the brief introduction. I did include my personal intro in my presentation, so I'm going to pull that up here, and we should be able to get started. Can you see that okay? Great.
Yeah.
Okay. Yeah, so thank you all so much for coming out tonight for this presentation. I have to start out by saying this was supposed to be a tag team effort. Unfortunately, my friend Bremen is not able to make it today. He became ill a couple days ago, thought he was going to be able to rally for this today, and unfortunately was not able to, so he had to call in sick for this. So I'm going to hopefully not fumble through it too much as far as his part, but we'll give it a good go here. So we titled our presentation, Put Your Money Where Your Mouth Is, a Value-Based Care and Clinical Imaging Utilization. Again, just brief introduction. Bremen, I'll briefly introduce him. He's an orthopedic resident at Sanford Health in Fargo here. He would be speaking a lot about what Sanford's doing in the primary care world today and how imaging is involved with that. He was a student of mine. He's a good friend of mine. And as I'll talk about briefly, he and I are both going through the clinical research PhD, excuse me, the PhD through the University of Jamestown. So that's a little bit about Bremen. I myself, assistant professor at the University of Jamestown PT program, as Brian had mentioned, and a little bit more about myself. Family of four. You can see my wife there, Carrie, daughter Collins, who's going to be turning 3 in February, and then our son Bowden, who's about a year and a half. And as you can tell from this photo, we are currently in the stage of our lives where we can never get all four of us to look at the camera at the same time and smile. You can see, in fact, usually it's hard to get more than two of us to do that. So if any of you are familiar with up north, north central Minnesota is where the Mississippi River begins, and that's where this picture was taken. The mighty Mississippi actually has a pretty humble beginning. You can easily walk across it here. So that's where that's at. I am in Fargo, North Dakota. I would give you a background on North Dakota and Fargo, but interestingly enough, over the last year, there have been two other presenters at this meeting from North Dakota, both Scott Brown, who I'll talk a little bit about. He's the director of rehab at Sanford Health here in Fargo, and then Matt Schumacher, who is just down I-94 from us in Bismarck, North Dakota, talked a little bit about some of the research he's doing with the University of Mary. So I won't talk about that much more. I am a Minnesota sports fan. Some would call it a sad life, and I would say for most of my life it has been pretty sad. If you were to ask me prior to the NFL season this year if the Vikings would be only have 2 losses after 11 or 12 games, I would say you're crazy. But here we are. Maybe this year is the year for the Vikings. I don't think that's the case. I think their record is maybe a little better than they truly are. But I would have said that the Minnesota Timberwolves were going to have a heck of a year, but they're sure enough off to a rocky start. So we'll see what happens with that. And then lastly, at the University of Jamestown, there's a slogan, Jimmy for life. And that's been the case for me. I went to UJ for undergrad in exercise science. I went to PT school at the University of Jamestown. After doing a orthopedic residency, a year and a half after graduating, I found myself back at the University of Jamestown in an assistant professor role and am currently in the first cohort of the PhD program for clinical research. So Jimmy for life applies to me quite well. I do want to say a few thank yous, and I'm going to start things off with a bit of a flop because I don't think Bruno is here right now. But I
Oh
wanted
yeah,
to
he
say
is.
Bruno is here. Okay.
Brian, thank you so much for giving me the prompt. Otherwise, I would have carried on talking with this patient for another hour, thinking that we were on another hour. So, profuse apologies, everyone.
Yeah, no worries, Bruno. I might need your input here in a second anyways. As I was looking for a photo on Google so I could put Bruno up here, I maybe found something even more interesting than a picture of Bruno.
Oh no.
Bruno, do you happen to be a professional chess player as well?
Yeah, as a matter of fact, Kasparov really is overrated. No, actually, no.
That is not the same Bruno Steiner, huh?
I am definitely not that Bruno
Okay,
Steiner.
okay. You strike me as a man of many talents. So
Although I think I probably could have milked the Kasparov thing just a little while longer.
Okay, yeah. So first, thank you, Bruno. It's a pleasure to get to know you this early in my career, and Bremen would say the same thing. So thank you for everything you've done so far. It's
Got
been
it.
tremendously influential for us. Next up, Scott Brown. I mentioned him already briefly. Scott was a presenter on this imaging SIG meeting within the last year. I think it was 10 months ago or something along those lines. And he's the director of rehab here in Fargo for Sanford Health. And he talked a lot about imaging privileges in North Dakota and how they're doing that at Sanford. So I'm going to brush up on some of that eventually in the presentation. But Scott has been a significant mentor of mine, and Bremen would say the same, both from a clinical perspective and from a leadership perspective. In addition to that, Tim Beyer is the supervisor of the spine clinic at Sanford Health here in Fargo. And the spine clinic, again, I'll talk about it more later, but it's a primary care spine clinic for people with back pain. And many providers would be quite apprehensive to allow young clinicians in a setting like that. But Tim has strongly advocated for myself and Bremen to be in that setting, and we're super grateful for that. And then last but not least, Mitch Wolden has had a great influence on my research up to this point, and I think Bremen would say the same. He's both Bremen and I's PhD advisor, and our research would look significantly different if it wasn't for Mitch. So thank you to these four, and I also want to mention thank you to everybody who's on this meeting who has published in this area previously. I'm going to reference some of you throughout this presentation. And it's just know that the work you've done has had a very positive impact on my early career, both as a clinician and as a researcher. So without further ado, let's get into some of the objectives. I hope to accomplish over the next half hour, let's say, a few of these objectives. First, what were the steps that led Bremen and I to the research that we ended up conducting? I want to bring you through some of the literature review that we did leading up to that as well. I'll present the research that we've conducted, which is currently under review. And then lastly, kind of flip the table, we're going to focus on the clinical implications of this specific research and beyond. So how do we get here? About a year ago, now. A year and a half ago, Bremen was a student here at UJPT with aspirations of working as a primary care provider in physical therapy, and I was an assistant professor at UJPT working in the spine clinic, which is a specialty clinic for people with back pain. So because of our mutual interests and our friendship, oftentimes Bremen would find himself in my office, and we would have a conversation that looks something like this. Not too often did we only talk about one topic, but instead we were all over the place many times. And unfortunately, I can probably say that we never solved any problems, but I can guarantee you one thing that we did, and that's we created a problem. And we both decided that we were going to pursue our PhD. So we decided to enroll together in the 2023 cohort of the clinical research PhD at the University of Jamestown. It is their first cohort, and it's been a good experience up to this point. We're about halfway done now. And as we were getting through the enrollment process, we looked at the curriculum, and during the second 8 weeks of the curriculum, we noticed that we were going to have to learn how to perform a systematic review and meta-analysis, and it would make sense for us to work towards a project if we could. So we started coming up with some of the ideas that we would maybe be interested in researching. And you can see some of our main interests here on the left: primary care PT, scope of practice, imaging, leadership, health policy, clinical decision making. There's many ideas. And so we found ourselves kind of spinning our wheels for a little while until we started coming across some of the work that some of you have done and some of the other researchers throughout the United States and even beyond, to be honest. And we decided that we were going to focus our attention for the systematic review and meta-analysis on primary care PT and the PT scope of practice. And underneath that would include things like imaging and other outcomes that I can talk about later on. We knew that after we came up with this idea that we would have to go through a literature review. To be completely honest with you, most of the research that I had read prior to this was focused on orthopedic research, as I had recently just finished with my orthopedic residency, and I was beginning to teach orthopedic classes here at the University of Jamestown. So I hadn't looked too much into the primary care research, and we were both pleasantly surprised at the amount of research that actually existed in this area. So here's a list of 9 different systematic reviews that already existed on the topic that we were interested in, comparing first contact physical therapy or direct access physical therapy or primary care physical therapy to usual primary care. You can see here, they're all systematic reviews with a couple of meta-analyses sprinkled in as well. And so when we saw this, we were wondering, well, we didn't think there was going to be that much out there. So is there even an opportunity to conduct another systematic review with potential meta-analysis? And so I'm going to bring you through some of the outcomes that these different reviews assessed, and then where we maybe found some of the gaps that we felt could still be filled. So the first, probably most obvious outcome that a lot of these studies looked at was health outcomes. And each of these 6 systematic reviews found that if a patient with a musculoskeletal disorder saw a physical therapist first versus usual primary care first, they achieved similar to superior health outcomes. And I want to make a note right now that it's resonated with me as I've conducted this research, and it's that when we're doing this type of research, we don't necessarily need to show that we are significantly better than these other providers. Although that would be awesome, and I think in a lot of cases we do see some of that. However, in order to get into these roles, we probably just need to show that we're doing an equally good job as these other providers who are already seeing these patients. And so when we see these results of similar to superior, that's really good news for us as physical therapists. The next outcome that we assessed as we looked through these different systematic reviews was patient satisfaction. Of course, this should always be high on our radar when we're seeing patients. We want to make sure that patients are satisfied with the care that they're receiving. And these 3 systematic reviews looked at that and found that patients were more satisfied when they saw a first contact physical therapist compared to seeing usual primary care for their musculoskeletal condition. Next up was, what happens to the demand on other providers if we integrate these first contact physical therapists or primary care physical therapists? And these 3 systematic reviews found that it actually improves the demand on these other providers. We hear a lot in the research and a lot of the conversations about how overwhelmed our healthcare systems are. And that comes down to our providers being overwhelmed as well. And so if we can somehow decrease the load of these different providers and still achieve similar to superior outcomes while utilizing more appropriate health services, that's a win-win-win. And so these systematic reviews found that it does in fact improve the demand on other providers. What we're going to be focusing on a lot more today is healthcare utilization when it comes in terms of imaging utilization. When we look at healthcare utilization in totality, these 4 systematic reviews found that PTs utilize healthcare services less often than other providers in a first contact position. And then when it comes to cost effectiveness, if we're utilizing less services, it should come as no surprise that seeing a PT first was in fact more cost effective for patients as well. So these 6 different reviews looked at that. And in conversations with different legislative efforts and everything, something that's always going to come up, and it should come up when we're talking about patient care, is patient safety. And as we look through these different systematic reviews, there wasn't one systematic review that identified a greater safety risk when seeing a first contact physical therapist compared to usual primary care. And that includes inappropriate imaging referrals. So some of the takeaways that we took, not only from these systematic reviews, but also the different observational and randomized control trials that we were looking at, is that musculoskeletal disorders are a significant problem. And that's no surprise to us. We know that. But it's not only a significant problem, it's the primary reason for years lived with disability worldwide. And when we see that worldwide, that's one of the reasons in our study that we focused on a global perspective as well. And we talk about physicians or providers being overwhelmed by the amount of patients that they're needing to see. Well, part of the reason for that is because 4 of the top 12 diagnoses seen in primary care are in fact musculoskeletal disorders. And who better to see these patients than physical therapists? Much of our training revolves around that system, and we are well equipped to be able to care for these patients in that role. Not only does it help with the providers and their burden or their increased demand, but also what we notice is that these MSKDs continue to rise the demand on these healthcare systems. So we can have a greater impact on healthcare systems rather than just looking at it from the provider level. Another point that we wanted to mention here in regards to the imaging in our literature review was that PTs are utilizing health services appropriately, including the imaging utilization. So after reviewing all of that, Bremen and I had to have a few conversations about what are the gaps here, if any, and is it worth pursuing another systematic review in this area? And so what we decided was, yes, we think it is worth it, because there wasn't one systematic review with meta-analysis that only looked at randomized control trials. In addition to, there hasn't been any systematic review with meta-analysis that looked specifically at imaging or prescription medication use. And so we decided that we were going to focus on doing a meta-analysis on only randomized control trials. That led us towards this. Like I said, this article is currently going through the review process. It's titled First Contact Physical Therapy Compared to Usual Primary Care for Musculoskeletal Disorders. And it's a systematic review and meta-analysis of randomized control trials. You see Bremen, myself, and then Mitch Wolden, who I mentioned was both of our PhD advisors, and the authorship there. So, like I mentioned, the research question, we're really trying to get at usual primary care versus first contact physical therapy for MSKDs. And the outcomes we wanted to assess were pain, disability, health-related quality of life, healthcare utilization. And under that, we wanted to focus on clinical imaging, which is what I'm going to talk about a lot today, and then prescription medication rates, along with the last outcome of cost. So from here, I'm going to talk about the study in some general terms, but I'm going to try and highlight more so the clinical imaging component of the study. Our methods, again, were to focus on randomized controlled trials. The inclusion criteria for the imaging meta-analysis specifically was the patient had to have some type of an MSKD. They couldn't be coming in with some other system involvement. It had to be primary complaint of some type of musculoskeletal disorder. The PTs had to direct the plan of care. So there were some studies that we ended up excluding because the patient had seen some type of a provider initially, and then from there they were randomized to either a PT or a different provider. In order to be included in our study, the first contact, the true first contact, needed to be after the randomization, and then they were either going in the FCPT group or the UPC group. And then again, specifically for the imaging component, PTs had to have imaging privileges either directly or indirectly. I'm going to mention the indirect component a little bit later on with one of the studies. I think it'll make more sense there. And then also, if the PTs were able to order those imaging or those images, we were going to focus on what does that retrospective data over that outcome timeframe look like. We ended up including 10 studies in our systematic review, and for the imaging meta-analysis, we included 4 different randomized control trials. The next thing I want to do is look at each of the 4 studies a little more isolated, so then I can show you what the results were from those, and then I'm going to pool it all together in our meta-analysis after that. So the first one, really common study that's highlighted in this area by Dacre-White in 1999. This was the largest sample size that we looked at for this specific outcome. In this study, PTs were able to directly order radiographs and then indirectly order MRI and CT. The total sample size was 481, and so that was divided relatively equally between the 2 groups. And you can see first contact physical therapy resulted in 108 images ordered versus usual primary care resulted in 178 images ordered. The next study that we looked at was done by Gagnon in 2021. PTs were able to directly order all diagnostic imaging, radiographs, looking at MRI, looking at CT scan. The sample size here was 78, again divided by 2, so nearly 40 in each group. First contact physical therapy resulted in 15 images ordered, and then the usual primary care group ended in 28 images ordered. The next one conducted by Ho Henriksen. This was a follow-up on a prior study by this group, and they looked at imaging rates based on retrospective health data. So the PTs were the primary assessor, and they found that it decreased the frequency of imaging. The sample size here was 69 in the first contact physical therapy group. There were 0 images directly ordered from the FCPT, and then in the UPC group, there were 4 images ordered. And then lastly, here PTs were able to order directly for all diagnostic imaging. This was done by OJA in 2020. So the sample size here was 150 participants, and the results you can see FCPT led to 1 image ordered, and then UPC led to 7 images ordered. I wanted to touch on the indirect component of the referrals as well. And along with that, I wanted to touch on the retrospective data. So I'm going to go back 1 slide here to the Ho Henriksen article. You can see here how it was based on retrospective data. So the reason that we chose to keep this along with the indirect referrals is because we still felt it was important if you go on to see a first contact physical therapist versus a usual primary care provider, if over that next year or whatever time frame it is, is that patient more likely to go and seek an image from some other provider or not? Because they would have that ability to do so in many cases. And so we felt if the usual primary care provider results in these increased referral rates over that time frame versus the FCPT provider still decrease the likelihood of them being given an image referral over that same time frame, that's still a win as long as they're used efficaciously and we're not missing anything. And so you can see based on these results that there's probably going to be less overall images referred from first contact physical therapy. And that's exactly what we found in our meta-analysis. So here's the pooled data from the 4 studies that I've highlighted. And we were really excited about these findings. Clinically significant, pretty good effect size, low heterogeneity. And then another thing that we see is the prediction interval, partially due to, well, due to several factors, but partially due to the low heterogeneity here, is also relatively small. So the overall effect was favoring first contact physical therapy as far as less images referred for at 0.59, and then the confidence interval goes from negative 0.79 to negative 0.39. So really not close to crossing that 0, which would demonstrate that clinical significance. And not only that, I mentioned the prediction interval. That's really close to 0 as well. If you look at some of the other meta-analyses that we ran with more dispersed outcomes, the prediction interval can get pretty long pretty easily because it's such a conservative measurement. So when we see these types of findings, I get really excited about that. I know it's hard to determine how we can use this clinically. So what we decided to do was take this log risk ratio, which is the number that we ended up getting here, and back calculate it to get the relative risk or the risk ratio for this. And the risk ratio was 0.55, meaning that patients who saw PT first were basically 45% less likely to receive a referral for diagnostic imaging. Pretty exciting findings, again, for the work that we're doing and PTs looking to get into these different legislative efforts in getting into this area. It's important to note that there are several limitations to our study. The bolded ones, I think, are more applicable to the imaging component. There's a limited amount of randomized control trials that we were able to include. There's 4 studies, that's really not a lot. I think the evidence is pretty strong there with the 4 studies that we do have. I think we see a pretty consistent theme. However, I would love to do this again when there's 10 randomized control trials looking at this exact same thing. So there's obviously further work that needs to be done here for that. The other thing that could be viewed as a limitation because of the lack of sample size and the number of patients or the number of studies where we were able to include is that this wasn't specific to one type of musculoskeletal disorder. So we could have only had one study looking at shoulder pain, only one study looking at low back pain, and that's all we have. So the generalizability to a specific patient population isn't very good. When we look more broadly at some of the limitations of our study and the different outcomes that we assessed, we found that some data was not available from certain studies. When we reached out to the authors, they weren't able to get us the necessary data to be able to run some of the meta-analyses. So we weren't able to include everything that we would have liked to. And then in the other outcomes, we didn't necessarily have this problem with the imaging part of it, but in some of the other outcomes, heterogeneity and the risk of publication bias were present. We didn't have more than 10 articles in any of the meta-analysis, so the publication bias can't truly be assessed anyways, but the heterogeneity is pretty high in several other outcomes that we assessed. So in conclusion for our study, I think this research adds to the current evidence supporting PTs being in a first contact role for musculoskeletal disorders. And when we talk specifically about imaging, the evidence that we viewed, even though there was only 4 randomized controlled trials, still found that there was a significant difference between referral rates when it comes to first contact physical therapy and usual primary care. Our overall, or if I could put our summary into one statement, it would probably be this. When compared to other providers, physical therapists utilize less imaging, prescribe less medication when given the privileges, and achieve similar to superior clinical outcomes. So that's kind of the blanket statement over the outcomes that we assessed. Interestingly enough, I don't want to get too far on this because it's not specific to imaging, but interestingly enough, I would have expected that the cost associated with care would have been significantly less in the PT group here because of all of the other systematic reviews that found that. And we also saw here that PTs utilize less imaging services and some of the other services. The cost ended up not actually being clinically significant. So that's not necessarily in alignment with some of the other studies, but I think we need to take all of that information in totality to be able to come to any good conclusions. So that's basically the information I wanted to provide about our study here today. The next thing I wanted to get into is pragmatic implications of a study like this and all of the other research that we currently have as well. And I wanted to talk about it briefly on 3 different levels: nationally, what's happening in North Dakota, and then specifically where I work as a PRN therapist, and then where Bremen is employed full-time in Sanford Health. And again, I just want to mention, unfortunately, Bremen's not here. He'd probably be able to speak to some of the Sanford Health stuff a little bit better, but I'm excited to give it a go here as well. So nationally, I think this study by Albright and Peterson that's in the PTJ has been really helpful for me to get a good picture of primary care physical therapy in the United States as it currently stands. And what they highlighted as far as access to care is that there's 2 primary pathways. Imaging referrals and privileges may differ depending on the pathway that's utilized, specifically at the different entities and the different states in which these pathways are utilized. The 2 different pathways that they talked about and have been highlighted in other areas as well would be the direct triage and the warm handoff model. The direct triage is when the system will directly refer the PT if specific pre-established criteria are met. Another recent study highlighted a specific flow chart or a set of criteria that would help you identify, okay, yep, this patient is safe to go and see a first contact physical therapist right away. And then they would go to that first contact physical therapist without seeing a provider beforehand. And then the other one would be a warm handoff, which has a few more pieces to it. So in a warm handoff model, the usual primary care identifies that the patient may be appropriate for physical therapy. Then they'll meet with the physical therapist to give them a brief synopsis on the patient presentation. From there, the physical therapist will go in, evaluate the patient, and then determine the appropriate management strategy for that patient. So at a national level, this is a very umbrella overview of where we're at currently. I know there's so many more details that could go into this, but I just wanted to briefly go through that because it's going to tie into what we're doing at Sanford a little bit later on. Next, I wanted to talk about North Dakota specifically and where we're at with our imaging privileges. In 2021, we were given the go-ahead to start ordering plain film radiographs as long as you met one of the criteria. It could either be a DPT degree or complete a board-approved formal medical training or imaging training. In the North Dakota State Practice Act, this statement can be found if the diagnostic process reveals findings outside the scope of physical therapist knowledge, experience, or expertise. A physical therapist shall inform the patient and client and refer the patient or client to an appropriate practitioner. And I was talking with a couple people before this even about how this isn't necessarily new to us. With every patient that we see, we need to ask ourselves, is this patient appropriate for physical therapy or not? Are we going to treat this patient? Are we going to treat and refer this patient, or are we going to refer this patient? And so it doesn't necessarily change what we do in practice. We already should be doing these things, but this is just how it's put in writing for the North Dakota Practice Act. I recently joined the Legislative and Bylaws Committee for the North Dakota APTA, and as we continue to navigate legislative efforts, we put together a brief infographic summarizing some of the literature that we looked at for advanced imaging. And so I wanted to just briefly run you through that. I split it up into 2 different slides, so I'm going to go there now. So only 2 to 4% of new evaluations performed by physical therapists are referred for advanced imaging. And in the studies we looked at, that was compared to about 20% of the new evaluations performed by other primary care providers. As we continue through the infograph, a couple other things that we wanted to highlight here was that 83 to 91% of physical therapist imaging referrals align with current ACR guidelines. An interesting thing with that, if we kind of shift our eyes over to the right here, is not only are we referring appropriately based on ACR guidelines, but our diagnostic concordance with imaging findings is on par with orthopedic surgeons. There were no significant differences between the diagnosis a physical therapist provided and the imaging findings compared to an orthopedic surgeon's diagnosis and the imaging findings. However, there was a significant difference between those 2 categories and the non-orthopedic providers. So you can see that our decision-making for ordering imaging is consistent with those orthopedic surgeons when it comes to diagnostic concordance. You all know all DPT programs are mandated to cover diagnostic imaging, and diagnostic imaging is included on the NPTE. And then lastly, again, when it comes to safety, 0 to 3% of patients experience an adverse event when PTs have the ability to order advanced imaging. And if you look into those specific numbers, some of those are questionable and pretty conservative numbers based on the actual incidents that occurred. So moving ahead specifically to Sanford here, like I said, I'm PRN, physical therapist at the spine clinic, and Bremen is currently an orthopedic resident there, where he's both at the spine clinic for 1 morning per week, in addition to being a part of a different primary care model as well. So to go back to the slide that I previously looked at, this is just word for word on that, just to remind you that the 2 main care pathways, direct triage and warm handoff, we've integrated both of these at Sanford Health here in Fargo. The direct triage model is more applied in the spine clinic that I'm at, and then the warm handoff is applied in various settings at Sanford Health here in the orthopedic walk-in, family medicine, and internal medicine. Now, if you want more details on some of this, I would highly recommend that you go back to Scott Brown's presentation in a meeting within the last year as well. He did a fantastic job about going through the details here and tracking some of the data along with that when it comes to imaging referrals. So I'll just try to briefly summarize some of that information, since you can go back and look at that if you're interested. But with the spine clinic, it's made up of chiropractors, physician assistants, and physical therapists. A patient will call in and get assigned to one of those providers. The first PTs to order radiographs in North Dakota were at the spine clinic for Sanford. We tracked our data for about a year before we started to integrate it in different aspects of physical therapy within Sanford and Fargo. And not only do PTs have the ability to order radiographs here, but we use a collaborative and interdisciplinary approach to indirectly order advanced imaging techniques and also order interventional pain management procedures. So through that interdisciplinary effort and interprofessional collaboration, there's many of the PTs that are in the spine clinic that are currently helping these different providers identify what the most appropriate imaging modality is for that patient, and in some cases what the most appropriate treatment interventions may be for that patient as well. I'm less confident in my ability to speak to this orthopedic walk-in stuff, but Bremen gave me a rundown, so I think I get the gist of it. When a patient goes into the Sanford orthopedic walk-in, as it currently stands, they're going to get a radiograph before they see a provider. I think that's pretty common practice in a lot of places. If you ask me, it needs to change. I just don't understand how that's the current process that everybody goes through. Patients are then seen by an orthopedic advanced practice provider, and then the APP is going to determine if the patient is appropriate for physical therapy. So here's that example of that warm handoff case or that pathway that Albright and Peterson talked about in their study. PT will then manage the plan of care if deemed appropriate for physical therapy. And then in another setting within Sanford Health here in Fargo, it would be the family medicine or internal medicine. Originally, this began with one physical therapist that was available one morning per week for that warm handoff from providers in this setting. Now they've kind of switched gears to a pool of 10 physical therapists, and the provider will message that pool if they have a patient who may be appropriate for physical therapy. And if anybody's available within that pool, they'll message them back, and then they'll go down and they'll see that patient in whatever setting it is. And then again, from there, the physical therapist is able to see them right away on that day one session, and they're able to collaborate with that provider to determine if imaging is warranted, to determine if physical therapy is appropriate, and if it is, what's the most appropriate plan for that patient. I want to summarize everything as best I can here with this take-home message. So our research found that first contact physical therapists order significantly less images than usual primary care in the studies that were included in our meta-analysis. And we would anticipate that decreasing imaging utilization may decrease cost for patients and healthcare systems. When you look at the evidence in totality, you would see that that's pretty clear in the evidence that we currently have. Policy barriers continue to limit PTs from acting as primary care providers for musculoskeletal conditions, and it's going to continue to be a battle that we're going to face. And I think that goes to the next point. The workers are few, but the harvest is plenty. We're going to continue to strive to make advances in our scope of practice, not because we just want to make advances in our scope of practice, but because we truly believe that it's better for our patients. If we can improve the care for our patients, of course, we're going to try and do everything we can to do that. And if we look at the evidence and our research that we've conducted up to this point, I think it's pretty clear that the evidence would suggest that we should be in these roles, helping make these decisions for patients who present with musculoskeletal disorders. And then the last thing I wanted to leave you with is creativity drives innovation. So there's some cases, for example, in the spine clinic where we don't have legislative authority to be able to order an MRI, but through developing relationships with other providers within the spine clinic and using a collaborative interdisciplinary approach, we've been able to collaborate in those decisions. So we aren't necessarily the ones ordering it, but we might be helping those providers make those decisions for the patients that are presenting to us. So again, creativity drives innovation. Get creative and try to figure out these different avenues that may be possible to improve the interprofessional care that our patients are receiving and improve the quality of healthcare utilization, specifically looking at imaging utilization for our patients. So that's all I've got. What questions does everybody have for me?
Dallas, that was wonderful. Thank you so much for doing that. And God, there's so much to feed off of in this. And I like, and that's the thing when you made a statement basically that maybe you're going off on the tangent of primary care and how this shows that we are effective in primary care. And but that's exactly what we're trying to prove with the imaging SIG. I mean, yes, we're being quite focused on the imaging component on how this fulfills our goals for primary care practice. So I think this is totally appropriate, and you're bringing it into a holistic view of what we have to offer as a profession. And there's so many points that I really like, but let's open it up to any questions anybody might have. Aaron, do you have anything to add to this? Aaron, Kyle?
Other than to say, wow, that was awesome. Way to go, Dallas. Really
Thanks,
appreciate
Aaron. I
it.
appreciate that. And if it wasn't for your work, I don't think Bremen nor I would be where we're at. So thank you for your work too.
Well, it's always good to see other folks that are as passionate about the topic, for sure. And I did have one question about the folks at Sanford you suggested that maybe some of the PTs are making recommendations for interventions, like I assume you're referring to epidurals or other types of injections. Tell us a little bit more about how that goes.
Yeah, you're exactly correct. So none of this would be possible without having some sort of physician at the helm. And thankfully, we've had a physician at the helm of this. Dr. Mahajan is one of our pain providers, and he has really helped initiate some of this. So currently, how it works in practice is if we feel as though the patient would benefit from lumbar ESI or something along those lines, we would send Dr. Mahajan a message saying, hey, this is what the patient is presenting with. This is what the patient has done so far. And this is what the imaging has found. We believe this patient may benefit from this type of procedure, injection, whatever it might be. And then at the end of the day, he's going to take that information, he's going to assess it all himself and determine whether or not he agrees with it. And he'll make the final decision on what the appropriate intervention would be.
Got it. You have someone who's willing to hear what you have to say, which is great, which is, still a little bit different than the physical therapist actually putting in the order for the ESI.
Yep, it is. It is different. Yep.
It is a construct, though, that's worthwhile. And at least people see the model of how that can work. So in hemophilia, making all kinds of recommendations, it's pretty well us that's making the imaging recommendations, and recommending orthopedic referral or what kind of procedures that the patient might benefit from. But that also, it's definitely not nothing. I mean, it just makes people realize that this is the value. It's very much grassroots advocacy for us within the multidisciplinary team. So I think this is a good development. I want to see that documented, though, down the road. Is like, we're the ones that make all these recommendations. I mean, yeah, so we do need more acknowledgement, I think. So I understand. I don't know what you went through with the introduction, Brian. Did you speak to? Did you guys already talk a little about what's going on in North Dakota in terms of the legislative initiative, or am I late to the party here?
We did not talk about that. I didn't know what you had planned, so we just kind of jumped to Dallas. There is a question from Lisa in the chat, though, for Dallas. I'm not sure if you have your chat pulled up and see that. If not, I can read it to you.
Yeah, so I have the chat pulled up. The question, what do you think is the future of malpractice insurance costs for PT with the increased responsibility of being assigned as the first provider and ordering imaging? To be completely honest, I don't know if I would be able to answer that question with any backing. Maybe somebody else on the call would be able to answer that with more to add, I guess.
I'll give it a stab.
Please.
Yeah.
Nothing.
Yeah.
Honestly, I mean, Aaron, do you see anything going on here? Because frankly, I don't see it. We're responsible for initial evaluations and coming up with a diagnosis, and we're getting a radiologist to give their reading. Oh my God, what terrible things can happen for physical therapy. Now, honestly, it just gives a layer of diagnostic certainty. So I just don't see it. And when somebody says, okay, well, if you refer for imaging, you own the diagnosis. That's like, the whole team owns the diagnosis. The radiologist owns the diagnosis. You own the patient. And God forbid, what are you going to do? I'm going to refer it to somebody. No, sorry. We tend to invent reasons that we might have a little more malpractice insurance. But am I speaking out of hand, Aaron? You're taking a deep breath.
No, I agree. And I'm, having been a part of the ordering world in the civilian sector for a long time now, I don't want to be cavalier about it at all, but I think there's more risk in not having imaging privileges because you end up saying, I think you need to get an x-ray, and then the patient never gets one. Who's that on?
Yeah.
So I think the data would support that, as you outlined tonight, Dallas, that therapists are really judicious users of this imaging privilege, and We follow published guidelines better than just about anybody. So those two things, set us up for success. We're not doing this haphazardly. It doesn't look like we are, at least. We're doing it less often than other people who have imaging privileges. And the question always comes up with, like, what are you going to do if you find cancer or something really, really bad? And I get the question, right, that we need to be able to have a plan for how we're going to manage the tumor, right, if we're the first ones to uncover it. But the plan is exactly the same as any other healthcare provider that might uncover the same finding.
Almost.
So we don't manage tumors. We
Well, it's
don't manage
5 to
fractures.
6.
Oh, SV.
Oh, got it. And yeah, that's my little soapbox. And could we catch bad things? Hopefully. Yeah, that's the point.
Yeah.
And to refer those people on to appropriate healthcare providers, just like everybody else does, is what we would do.
The thing is, it's a scary question, and this is what dumbfounds us when we're in a room with other physicians. What if you find cancer? What are you going to do with it? It's like, oh my God. But and like Aaron says, I hope we find nefarious stuff. What if we're the last people that you can get an imaging referral order from in a rural section of the country? Hopefully you're at least there that you can actually make that order. So you found something, and so then you can do something if you're the last person standing there. I mean, wouldn't you want to have a physical therapist that actually has those privileges to at least go like catch it earlier? I mean, let's be real. There's some real practicality involved in this. Brian, you were about to say something.
Yeah, I just pulled up the HPSO website, the company that does probably the majority of malpractice insurance support for PTs. And the most common allegation against PTs is improper management over patients' treatment and probably clinical decision making. I would add into that one, if we don't listen to them and get a good plan of care, if we fail to act, we're just as probably liable, versus recommendations like you said, Aaron, or other things. But from what we see from both the military side of doing it for 20 some years and now being a recommender at Texas, we can't order yet. In this is, as long as we take care of the patient and we care about them, we give the recommendations and do the level of our license that it's allowed. I don't think it's going to increase responsibility or cost for us unless we fail to act within our scope of practice.
Dallas, I got a question for you. And again, the reason I wanted you, both you doctors, Ehrmantraut and Abul, was that you're the future standard bearers of our profession. You guys are the flame that keeps us going. And it's encouraging for me to know that you've got such a fire for this issue. Do you find your generation of physical therapists coming into it, how important is this issue for you? Because I know it's important for me, but I'm 61 right now. And I've been howling at the moon for decades now. So how do you bring us up to date on all things DPT going on right now?
Yeah, I'm really glad that you brought that up, Bruno. I think I can see it in my students. I see it in myself and my colleagues who are recent graduates as well, and how passionate we are towards this. And I think, I meant to bring this up earlier, actually. Another study we just finished data collection on is going to be pretty interesting. And a lot of our survey takers have less than 10 years of experience. And when we asked them questions, brief overview, I guess, of the study. So we asked chiropractors, PAs, NPs, and PTs to rate their level of agreement or belief on certain statements. And the certain statements were in regards to first contact provider ability to care for patients with MSKDs, their education and how well it prepares them to care for MSKDs, and scope of practice questions, such as, I believe this provider should be able to order conventional imaging. I believe this provider should be able to order advanced imaging. And what we see in some of the results, early preliminary results, is these younger PTs are really passionate and believe that they belong. they're excited about these different advancements in the scope of practice because they're being taught it within our school systems, and that they don't really know anything else. So when they get out into the clinic, it's like, what are we waiting for? Let's get after it. And we're seeing this in the preliminary data that we're looking at. So I'm really excited to see what comes out of that too.
I would echo that. I would echo that. We see that in primary care screening, ability to screen someone who is medically referred versus direct access. And we see it in beliefs if direct access is an advanced skill set versus an entry-level skill set like the DPT is supposed to bring to us. And for those that currently teach medical screening, Mike Ross and I run a paper, 25% of those that teach medical screening in entry-level DPT felt it was advanced practice. The paper we have in second review right now, I think about 35% of CIs think that medical screening for direct access is an advanced skill set beyond entry level. So I think what you're talking about, Bruno, your question, and Dallas, your answer here is, we have this group that it's not yet germane to us to do that, but the younger generations are learning this, and how are we balancing this ability to practice? There's a chasm here to bridge in this mix, and it'd be great to explore more how we can emphasize the need to complete that bridge to take care of the patients in front of us truly as best we can.
That's really well said, Brian, and exactly what I was trying to get at as well. Yep, that's great.
Yeah. There's another question here, Garrett, in the chat.
Okay, so why do you think there's no clinically significant difference in cost when we see these decreased utilization of services? To be honest, that was probably the biggest surprise for Bremen and I. When you look at the other systematic reviews, decreased cost. When you look at the decreased utilization of services in our meta-analysis, you would assume decreased cost. I can tell you that it just crossed the line. The confidence interval just crossed the line. So again, it favors first contact physical therapy, but I'll reiterate that was the surprise to us, and I don't know the specific reason.
We just need more studies. Here's the funny thing, and I mentioned this before. I just finished another piece of another big piece of the puzzle of our advocacy kit. And the cost savings, I got to tell you, it might be an attractive thing for payers. It'll be attractive thing for people who've gone down the road in the rabbit hole of cost and value of physical therapy. But if you're trying to advocate that to a hospital system that makes more money off imaging, it's not necessarily the point you want to advocate for. You got to know your audience and who you're selling this to. So, for a bunch of people, this is not the issue they want to hear. So when you advocate for this, just speaking aside here in the meta world, great argument for payers, super. For hospital administrators, where they go like, oh, you're telling us that you can actually lower our services. We're going to have a discussion with our board. So, it might actually kind of run counter to the goals we want to achieve. So know your audience. That's all I'm saying. But clearly we do have to watch, we have to watch out for our healthcare dollars. But like you said, Dallas, it's all about good policy. And we always have to bring it back to the narrative of good policy and serving our public and their interests. So really happy about that. Do you guys mind me going through a couple of points here, just to get through this meeting? Again, I apologize coming so late to the game here, but is it all right if I share? Or great, because I do have some sort of news going on here. Essentially right here, I got pictures of Scott Brown and Matt Schumacher, and essentially just to give a little more information here, they are our dear colleagues, champions, and former guests, and they are currently fighting the good fight for full imaging referral privileges to better serve the public of North Dakota. And North Dakotans are unsatisfied with the current strictures limiting physical therapists to radiography, plain films referral. And that's triggered this surge of advocacy in the Rough Rider state to actually actualize proper primary care physical therapy for the public good. And And that's the thing that I love that holistic message that you're bringing forward, Dallas. This really is part of the fabric of being a primary care provider. So North Dakota physical therapists have organized and girded themselves for this campaign, and they're engaging the institutions and physicians in the interest of this sound policy. And they're getting they're gathering support and marshaling evidence, and we at the Rapid Response Imaging SIG have been helping them in any way they want us to, with resources, documentation, and even if it's just to bounce ideas back and forth with, and we're honored to help in this in their historic efforts. So they're really doing their work is really crucial. They're in a pretty crucial phase. It looks pretty good, but we'll see. But I wanted to actually get into some of the business here. Just want to let you know, this is I just want you to be able to check out and unpack my Christmas present to everyone in the winter 2024 newsletters. Those who actually read them have come to know that I can't seem to limit my titles to short and snappy. They tend to be the creak under the weight of my penchant for verbosity. But check it out in the upcoming issue of the AOPT's Orthopedic Physical Therapy Practice magazine. The title is Tennessee Triumphant, Imaging Victory for the Volunteer State, and Here's Your Holiday Present, a guide to removing the pain and the rebuttal, moving from permission-seeking supplicant to effective advocacy and engagement, responses to the age-old objections and challenges from uniformly uninformed stakeholders, lobbies, and recalcitrant rivals, Imaging SIG President's message. So that's obviously just a paragraph. It's not really a title, but I just can't stop. And I've used this newsletter. It's kind of my Trojan horse way to introduce a document that's near and dear to my heart. And it's the final piece to what I'm calling our PT imaging advocacy suite of documents. And the reason I want to do this was that I find the physical therapists, including myself, we tend to be woefully unprepared for negotiations, rebuttals, challenges, misrepresentations, and false equivalencies that are often thrown our way during confrontations with physicians, stakeholders, and all these recalcitrant adversaries, and frankly, even within uninformed colleagues within and without our profession. So often we're in a room with just for a few minutes to make our point with maximal impact and not look like deer caught in headlights. So you'd be surprised how, maybe you're not so surprised, how easy it is to get thrown off our game. So it comes down to getting prepped with a script that we need to nail down. And as I like to repeat, luck favors the prepared. And as the legendary negotiator Chris Voss says, you do not rise to the occasion, you sink to the lowest level of preparation. So from all our collective experiences, I've compiled about 18 and running, typical or not so typical boilerplate platitudes and blissfully evidence-free challenges flung at us whenever we try to realize our primary care mission. And more importantly, we've provided the calibrated rebuttals modeled after negotiation principles, which I won't get into here. And like I said, it's 18 challenges, but this is a living document, and the list is surely going to grow as we collect more challenges through other state initiatives and legislative approaches. So when you enter the room or corridor or Zoom, and you have to try to engage your audience, build trust quickly, and be ready to respond in an unequivocal manner with empathy and respect. But you have to represent our profession well. So maybe even consult with us before to get some resources, as well as using us as a sounding board. Anyways, and I know how important evidence is going to be in our arguments, and we have to be ready to have more of these studies come out. And saying that, and Dr. Aaron Kyle, I'm so desperately waiting for the result of your research and its imminent publication. So you got to let us know as soon as it comes out, so we can build our arguments on it. But with all the evidence that we have, we still have to create a powerful, convincing narrative, and that's going to win the day. So of note, the Orthopedic Physical Therapy Practice Journal is going to be online only right now, but we'll e-blast the newsletter to our membership when it comes out. onward. I've got some surprising or unsurprising news for you. It looks like you're stuck with me for another 3 years. I ran uncontested for another term, and I hope it's a vote of confidence, but maybe it's just pure laziness. Who knows? I do believe our collective strategy continues to be working as physical therapists continue to have an insatiable appetite for all things imaging and diagnostic ultrasound, and cool developments that I think are defining our approach to advocacy, or at least it's we're actually circling the wagons here, and showing, at least within the House of Delegates in our national organization, that we've really taken in and integrated and really taking ownership of this idea that we are primary care practitioners. So it says they came to a resolution in the last month, actually, refining the language. Physical therapist services in primary care. Physical therapists possess clinical expertise in the prevention and management of common health conditions seen in primary care settings. Physical therapists practicing in primary care improve the health of society. I think that's a robust statement. I think we can build on that. Nurse practitioners and PAs seem to have they've cornered the statement advanced practitioners, but we need to, as a doctoral level profession, to own something too, to make a statement that we are there in a primary care role, and we can do it well, particularly with MSKDs, as Dallas said. To that effect, there's another magazine, just a recent APTA magazine came out. You can see, dealing with the whole idea of primary care providers as physical therapists. Here we see Lance Mabry, who's been a guest as well. It kind of looks like he's doing a ninja move right there. It's an excellent shot. It's a lot of action. Anyways, put it on your calendar, folks, because Houston, we have a symposium. The countdown is on for CSM 2025 in Houston, also known as Space City, home of NASA's Lyndon Johnson Space Center. And yes, indeed, CSM 2025 is set to launch on Thursday, February 13th, continuing through to the 15th. I'm looking to seeing everyone there, and I'm sad to say that there's not going to be an in-person meeting for the imaging SIG, but we'll probably do one virtually in late January, or more likely after CSM. Brian, any news as far as our content goes with CSM this year?
Yeah, Jim Dauber is leading that. I can't be the person as the point in presentation, so Jim is running that with our panel for our 2-hour session, and so that's all getting uploaded and processed, and they've been working that diligently. So it's going to be another promising, exciting, information-filled session on imaging and our masterclass series as it continues.
That's awesome. I think this is just such a great staple for CSM, and Brian, you're such a master of ceremonies. But James is going to do a great job filling in. So thanks for keeping that going and that energy going. Like I said, I think it's absolutely necessary that we keep this type of content going for CSM. So thanks for that. I'm going to say it. People watch that. People are actually kind of watching these membership meetings on YouTube. So thank you for staying with us. But these actually do get a certain number of views, and it's pretty impressive. So I tend to go off and promote things. I believe in repetition. That's the way to get the message out. And here I go again, and I'm not letting you off the hook. You absolutely need to learn and use diagnostic ultrasound imaging. It's transformational physical therapy practice. Please incorporate it into your professional and academic lives and get involved in promoting it. And I think I'm getting in the habit of showing some really cool stuff we encounter on a daily basis when we use MUSCUS at the Washington Center for Bleeding Disorders in Seattle. I have to remind people that hemophilia care is actually hyper supercharged orthopedics. Here's a 53-year-old male who rolled his right ankle on Saturday while walking his dog. Our nursing staff insisted that he see us for physical and muscus evaluation to rule out or rule in hemarthrosis and other complications. I think everybody knows that this fellow probably has hemarthrosis going on. Anyways, he came in non-weight bearing with crutches the following day, and he didn't feel the need to come, but he came in nonetheless because we insisted. So just to give you a quick view here, this is a normal short axis view of the talus and the talar dome. You can see the thumbnail on the right-hand corner, and this is the structure that we kind of pay attention to. This is the combined interface of the synovium, fat pad, and capsule for the anterior ankle in a normal asymptomatic ankle. And this is what this fellow looked like. So you see just something completely different and a really distended looking intra-articular space pushing the capsule superficially in longitudinal axis. You can see how it is pretty conspicuous there in terms of distending the capsule above and all this swirling stuff. This is the shin, this is the tibia, this is the talar dome right here. This is the neck of the talus body, and just using the real-time features of ultrasound, just being able to see and verifying whether it is fluid or not. Sure is, with some level of clotting going on, but this was really suspicious. Going to the lateral mortise, where you see the lateral edge of the talus, you see the band of cartilage right above it, and then the interface sign. Here's more of the fibula, but and this is the sinus tarsi right here. You see all this muck and blood. And so like, okay, my job's done, essentially. I basically say, yeah, confirmed there's a bleed in the joint. We have to administer factor replacement therapies for these people. But we just thought this is not looking right. The symptoms are off. Using our physical therapy judgment, we decided, you know what, we're going to look a little further along the fibula. And this is what we found. So you see this little crab claw that moves with plantar flexion and dorsiflexion. Look at this motion that you can see with such great definition. You can see essentially blood coming out of this area. So what is it? Well, I think you all know. So we basically told him, so we got a picture. We wanted to know how extensive this fracture would be. So we had it compared with radiography, and then we had that. So it's kind of exciting to see that and contrast it with ultrasound. This is just all to let you know how wonderful ultrasound is in that lengthy way, and just show you a couple of images. I got to remind you that the APT formally declares ultrasound as part of the practice, and part of the scope of practice for physical therapists. Institutional support for it runs from the American Institute of Ultrasound and Medicine, that regard us as licensed medical professionals to do this type of imaging. Speaking of tremendously important synergies, the gold standard credentialing body Intelios and their registries recognize physical therapist eligibility for their certifications. And more specifically, we should all be taking advantage of the incredible privilege of sitting the RMSK physician's credential for muscus imaging, governed by Intelios's Alliance for Physician Certification Advancement. And I would be remiss if I didn't tell you to take advantage of Intelios's POCUS Academy Selection of Certification, which we physical therapists are explicitly invited to work toward. We're in constant communication with these guys. They want us to attend their courses, including all that's on that list: pulmonary, visceral, pelvic, abdominal, of course, MSK applications, even vascular ones. So anyways, I'm going to skip through this. You all know that we've got recorded meetings, and they're on our website and they're on YouTube. And just wanted to get in quick with the nationwide scorecard. There's some important stuff here that I want to get through, and then we can say we can adjourn until the holidays. So much is happening, so many irons in the fire, and I only have time to share the hottest ones in play. But know this, I can rattle off numerous other states that are getting geared up. I'm really excited. That's why I literally have no time anymore. But here we go. All in deep green, we are able to order everything. Light green, like North Dakota, only imaging for radiography. The gray states, largely silent practice acts, and they're largely neutral with effectively no prohibitions to imaging referral. What does that mean? Well, no one's going to stop you from imaging referral. You might have to talk with some radiology practices and centers if they have any questions about physical therapists ordering. But, this has been a really successful approach for a lot of independent physical therapists who have wanted to have access to imaging or referral privileges. So in red on the map, there are strict prohibitions or explicit. And, I think this happened, when you read these practice acts, you're going like, who the hell wrote them? It seemed like all the other lobbies got a chance to hack away at our practice act. And I feel like these are due to kind of unforced errors, self-sabotage, maybe some real archaic views from within and without our profession. And you've heard me say it before, but we need to have board members and leadership that are in tune with our present realities of primary care practice and our educational realities. So I think it's a time for leadership on a change on leadership on this. And to you, I say, get involved and be part of the change you want to see. Go for a board appointment, become a board member, be part of the APTA, get your RMSK, be the change. So anyways, let's go through it. So the most recent one was Tennessee. Super effort done by the imaging leaders, the APTA leadership there, and they got a pass with, basically got a board ruling with no muss, no fuss. So super development. So we're basically flanking the states that are demarked in red with their prohibitions. Wyoming, I'm still waiting for a result from a state board member who really is in support, but he's trying to craft the language to address it. Kentucky is going through a legislative campaign. I don't know how it's going. They're pretty well prepped, but they're getting a bunch of resistance from the Kentucky Medical Association. They're always asking for more evidence. Frankly, I think they're just trying to slow walk it. This is the typical playbook. We're going to win that fight with a good narrative and convincing the legislators that we need to move forward for their public. So let's wait and see. North Dakota, of course, full gear, full bore. We're just, I think some good things are happening there. Crossing my fingers. We got such a good crew there. Pennsylvania, there has been a challenge from the Rad Tech Board. I haven't heard any word on that. Some fresh news surely going to come in January. Maine is something I really want to talk about. There's some really good motion there. There's, really exciting stuff going on with even a radiology center that spans 30 states that really want physical therapy referrals. I'm so excited. I don't want to give too much away, but oh my God. I'll keep you posted. Let's put it that way. I don't want to say more than that. Remember, we essentially would just want the privileges that they have in the military branches and Department of Defense, where they have no prohibitions to imaging referral. And this is what we want to be able to do for a civilian populations. They've been showing that it's an effective approach and they've been doing it since the 1970s. So, here's the funny thing, Dallas, we're looking, people say, well, we need evidence to show people. Well, what evidence did the Department of Defense have when they decided this was a good idea in the 1970s? What did they go on to make that happen? So sometimes I think we just need to be powerful negotiators and provide a compelling reason why we should be getting this. So that's just a thought. Anyways, that's it. Any questions about the update, please feel free to ask.
Hey, Bruno, this is Mike Ross. Could you stand for a second and talk to me?
Yeah, I sure can.
Thank you, sir.
Right on. We can talk now.
Well, I think you'd reached out to me, and Lance had as well, about New York State,
Yeah,
about some possibilities there as well.
right. Exactly. Those are all the other states that are really intensely interested.
Yep.
And looking over your practice act, I'm just I think it's in gear. It's just, there's just every state has their intricacies, and some states are able to provide a ruling. Some state boards are not allowed to provide rulings. So I'm really intrigued about the possibilities in New York, and I'm not really seeing any obstacles. Some people are seeing them. You want let's talk Turkey right now. What do you think?
I think it's a good possibility, to be honest with you. I sat on delegate assembly last year. I'm going to be on it again this year, and so I think there's a good push for it. And any help we can get from you or Lance or anybody who's done this before would be great, I think.
Yeah, and I don't think we need to go with a legislative approach. I mean, I really think it's
I
a
agree.
you've got to have your full game on when it comes to a legislative approach.
I agree.
And I don't think it's unless you're super prepared and you're not only with your arguments, but with the energy that you have to devote to it.
Yeah.
Frankly, I think there's a lot simpler approaches when you have a Silent Practice Act and you essentially ask a
Yeah.
really good legalistic question, and that provides education to the person you're asking. So we have model inquiries and iterations of that from previous states, and frankly, they're all built on the work from Aaron Kyle. So
Right.
he's so he might have been an inspiration to you, Dallas, but he's been every inspiration to me, because really this is how we have to approach the question. That's why I like saying we can't go from supplicant. I mean, we can't keep being the supplicant. Uh,
Yeah.
we have to look at our own practice act and go, well, what are the possibilities given the realities of our education, and how can we be politically expedient and exercise our options for the patient's good. So Mike, yeah, I look at it. I've been discussing it. I've been having conversations with a few New Yorkers who really want
Yep.
this to be in gear. My only advice was I kind of wanted, if you got meetings going on, so we can see the composition of the board and see where their mindset is, get a feel for their process as we make an approach to them. But I think this is the way forward. And like I said, we don't have to reinvent the wheel. We've created the language and the questions and,
Yep.
and the secret sauce of the question, really. And it's not manipulative, but you have to provide context, the why you want to do this, why you're asking this. Provide a background and history, because not all board members really are boned up on this issue.
That's right.
And then have a strict interpretation of the Practice Act based on a question of prohibition, duty of referral, and then craft an elegant question. But I'll tell you what not to do. This is poison to our profession and poison to our patient. I know that's dramatic to say, but do not let anybody ask the question of, Mother, may I?
Yeah.
Or ask, is imaging part of our scope of practice? Imaging referral? Sorry, I sound glib and hostile, but I swear to God, this is the type of question that gets us in trouble. Because when somebody looks at a practice act and they go line by line, say imaging. So there's nothing about imaging here. I guess not. So it's not part of our scope of practice. That's not the way to ask a question. I think you know what I mean. Aaron, you are the brainchild of this method. You got a comment on this?
Nothing really to add other than a question for you, Mike. Would it be helpful to have someone from hospital special surgery supporting the initiative?
Absolutely. Yep.
I'll put you in contact if you don't know her already. Jamie Edelstein. She's a vice president there, and she's very, very interested in having imaging privileges at HSS.
Yeah.
And we help them get direct access at the hospital. So I will connect you two and see if maybe you
That'd be
can come up
great.
with a game plan.
That'd be great, Aaron. I
Yep.
said, I sat on the delegate assembly the first time last year. I'm going to do it again this June, and I think there's a real opportunity. And Bruno had reached out to me with Lance's guidance, I think, and I think we have a real chance to make a real impact here. And so in New York State, so which would be, I think, a big state to kind
Yeah.
of get flipped.
Well, yeah, it'd be critical, actually. I would say that the more signatures you have on the inquiry, the better. Just a wall of inquiry, where people realize, oh my God, this is a
Yep.
bigger issue than just one person asking it. And I think that's really effective. And that's when, frankly, the board realizes, like, oh, this is salient. We better think carefully about this. So that's the preliminarily, that's what I'd say.
That'd be great. Thank you, Aaron. I appreciate you getting me in touch with them. Thank you.
Dallas, guess sorry for the complication at the beginning. It's kind of a wild ride here with patient care in the bleeding disorders community. So deepest apologies. And thank you so much for filling in and carrying the whole load. Sorry, Bremen had to sit it out. He certainly is delightful to talk to and collaborate with. And like I said, I'm deeply moved that you guys are carrying the fire forward, and I want you on as guests again. This is not the end of it. Maybe when you have the full publication out, I'd be delighted to run this again and tape this again for physical therapists. They need to know this stuff. So thank you so much.
Absolutely, Bruno.
Folks, have a great December. I hope everybody gets to spend a lot of good time with family and friends for Christmas and holidays, and a great New Year's and great things to come. There is a lot of activity ahead. We are crossing our fingers for North Dakota. I want good things to happen, but as long as we're fighting the good fight, nothing is lost. So really appreciate it. Thank you so much, everyone. And we will see you in the new year.